Unit 13 is sort of a carryover from Unit 12, and by that I mean Unit 12 is the diagnosis, the categorization, and the characterization of psychological disorders, according to all of the classifications and categories of psychological disorders that can be diagnosed using the Diagnostic Statistic Manual of recognized diseases or disorders. So Unit 13 is a carryover from that, in that it is the treatment therapies for the disorder. So we'll get into sort of the history of psychological therapy. That's how the unit begins. It is a comparison of where psychological therapies came from at the turn of the 20th century, the early 1900s, really for the first third of the 1900s of the 20th century. The prevailing therapy of choice by psychologists was Freudian psychoanalysis. So what we know about Freud is psychodynamics or psychoanalysis. It is the idea to access the unconscious mind, and using free association, using hypnosis, even dream interpretation. Freud believed that dreams were the royal pathway or the royal highway to the unconscious mind. And the idea behind psychoanalysis as a therapeutic approach is to access the unconscious mind, to help people confront or be faced with their deep-rooted id unconscious desires. And so the psychodynamic approach is the carryover from early psychoanalysis, with less emphasis on the psychosexual stages in some of the psychodynamic neo-Freudians, and more emphasis on childhood conflicts and unconscious forces. You get people like Carl Jung with the collective unconscious and the archetypes of the id or archetypes of the unconscious. And you get Alfred Adler, who has inferiority complex theory, birth order theory, and then the other neo-Freudians as well. So psychoanalysis is sort of the early school of 20th century psychology, and so to use psychoanalysis as a therapeutic approach would be to take the theories of Sigmund Freud as a way to treat anxiety, depression, phobias, and things like that. Freud would have believed that those were deep-rooted unconscious forces. The vocab that's important to understand is this idea of resistance, ego resistance to therapy. What the ego would do is prevent, by using some kind of physical manifestation, whether it is a shudder or stuttering or something somatic that has a physiological manifestation of a symptom that would be used by the ego to prevent threatening impulses from being revealed from the unconscious mind. So that would be a form of resistance that takes place or happens during a therapy session. Then you have this other psychoanalytic word that is transference, and that is a term in which a patient spends enough time with their psychoanalyst therapist, and so they begin to transfer deep-seated emotional feelings towards the therapist, whether it's anger and aggression and hatred that originally was aimed at a parent, and then they sort of transfer those impulses onto their therapist, or even if it's romantic love, that can also manifest itself or transfer itself onto the therapist. You have humanistic therapies, sort of the alternative to psychoanalysis, sandwiched in between the psychoanalytic period and the time period where humanistic therapy was widely used. You have behaviorism, but humanistic theory and psychoanalysis are often compared when it comes to therapies because they're both referred to as insight therapies, and that is the idea that the goal of therapy is to help a patient discover or gain some insight, to shed some light on what the source of their anxiety or their stress trigger or their depression may be. So in that way, that's what the term insight therapy refers to. But you also have humanistic terms, people like Carl Rogers. Carl Rogers theorized this client-centered therapy approach by using active listening, and what he referred to as unconditional positive regard, which is a term that refers to the client, not to the therapist, and that is teaching people who have self-esteem issues or people who have deep-rooted depression, teaching them techniques to learn to value themselves, build their self-image, and to discover what it is that they have the ability to do well and focus on. Active listening is a therapeutic part of client-centered therapy that was proposed by Carl Rogers also, and that involves an actual set of techniques for listening effectively from therapist to client. Things like repeating the question or repeating details from a comment that a patient would make, a client would make, to asking for clarification, leaning forward, displaying open body language. So all of these things that were intentionally done by Carl Rogers in order to convey to his clients that he is in fact listening to them and values what they have to say. The term client is a uniquely humanistic term also. In Freudian psychoanalysis, they would have been referred to as patients, as in the medical tradition, but Carl Rogers was careful to use the verbiage of clients rather than patients as part of his therapeutic approach. It wasn't so much that it was doctor-centered and trying to treat someone who was damaged or wounded or what have you, but it's centered around the client. So then we get into behaviorism. Behaviorism is kind of sandwiched into those decades in between the 1900s and 1920s, which is when Freudian psychoanalysis or psychodynamics really were at their heyday in terms of therapeutic approach. Then you get from the 1920s really till about the 1960s, behaviorism is all the rage among therapists as a way to treat their clients. Behavioral therapy has benefits, is effective, very effective in using counter-conditioning techniques to eliminate specific phobias, to eliminate generalized anxieties, and to combat addictive behaviors and things like that. So behavioral theory or behavioral therapy is exactly that. It is the idea that the therapeutic approach to solving a patient's problem is going to be based on behavioral theory. So people like John Watson with classical conditioning, if he can condition a fear into baby Albert to have a phobia of furry animals and Santa Claus masks and things like that, then if that fear can be conditioned in through classical conditioning, then conventional wisdom says that that fear can be conditioned back out. So counter conditioning is the classical conditioning approach of extincting, to use the behavioral term would be extinction, to take a stress or phobia, anxiety trigger that is associated with that emotional response and to recondition it in the opposite direction so it doesn't evoke a negative response, it evokes a positive emotional response. So you get things like systematic desensitization, which is one type of exposure therapy, and you get virtual reality exposure therapy. And exposure therapy is just a term that means we are treating, or the doctor, the medical professional, the psychologist, whatever title the mental health professional has. It's a term that means that the disorder is being treated by directly exposing the client to their fear trigger or their fear stimulus, and as a way to slowly gain some control back over that fear. So an example of exposure therapy to eliminate a phobia would be if a client has arachnophobia, an irrational fear of spiders, then a type of exposure therapy might be using virtual reality so that you could immerse them in a digital world which they were entirely in control, and introduce spiders or spider-like objects into the virtual simulation. Or another type of exposure therapy to fight arachnophobia would be systematic desensitization, which would be using Joseph Wolf's techniques that he developed based on his theory that you cannot have two competing emotional states at the same time. So the idea behind systematic desensitization is that if you use a relaxation technique, then it will banish the anxiety. So what Wolpe did was he taught coping mechanisms in the form of relaxation techniques to his highly anxious clients, and slowly introduced increasing levels in the anxiety hierarchy, until and taught them to practice their relaxation techniques so that eventually they could get to the point where when they had a bout of anxiety, they use their coping relaxation strategies and they lose, hopefully, the stress response to the stimulus. So that would be helpful in PTSD scenarios if people are have post-traumatic stress from a car accident or from combat. You can teach relaxation strategies as a way to combat anxiety in very specific situations. Going along with cognitive therapy, so we talked behavioral therapy is specifically aimed at the behavior itself. So it's using conditioning to eliminate unwanted or maladaptive behaviors. So phobias, anxieties, even addictions. When you look at cognitive therapies, those are specifically related to cognition, thought processes, paradigms or ideologies, or distorted cognitive distortions that people suffer from. And that's the idea that their thought processes are at the root of their depression or their anxiety or their phobias or what have you. So in order to treat a thought disorder, you would have to teach a new cognitive process. So cognitive therapies teach people new adaptive ways of changing their thinking or changing the way that they see the world in a perspective. And the idea behind cognitive therapy is quite simply that the internal belief system is driving the disordered category. So in the case of the module that's on the right there, the graph that's on the right, you get the stimulus, which is a lost job. The belief or the cognitive stance is I'm worthless, it's hopeless, so sort of a learned helplessness situation. And then the reaction to that negative thought process would be a slip into clinical depression. The other way to look at that is another thought distortion would be lose a job, my boss is a jerk, I deserve something better, which would be kind of a diffusion of personal responsibility or an external locus of control. And the benefit in that case would be that there's no depression. But obviously that may not be a healthy thought process either, because you get cognitive distortions, or you get an external locus of control where people don't accept responsibility for their own personal problems. So when you combine cognitive therapies, which are specifically aimed at thought processes, with behavioral therapies, which are specifically aimed at behaviors, obviously, you get Aaron Beck's cognitive behavioral therapy. And cognitive behavioral therapy is a combination of both. You change people's thought processes by helping them recognize unwanted or maladaptive thoughts, what Beck called cognitive distortions, and use behavioral techniques to hopefully integrate a new paradigm shift or a new thought process shift to positive thoughts. And that's the cognitive side of the therapy, by teaching people to recognize their cognitive distortions or their maladaptive thoughts. And you use behavioral techniques to help train in better behaviors or actions along with that process. So it's a combination. You have group and family therapies that fall in that cognitive behavioral therapy banner as well. So if you look at the bottom of the screen there, table 13.1, you have the psychodynamic, which is neo-Freudian. The assumed problem for that psychological disorder, so let's say that it is depression for each of these. The psychodynamic assumption for that source of that problem would be unconscious forces or childhood experiences. The aim in psychodynamic therapy would be to reduce the anxiety through insight. So hopefully the idea is that if you can identify the source of the depression, that maybe that will help you combat the depression. And how they're going to do that in psychodynamics would be psychoanalysis and interpretation of some kind. In the client-centered approach of Carl Rogers, the assumed problem for depression or anxiety would be barriers to self-understanding and self-acceptance. So again, some type of insight. The aim for client-centered therapy is growth, so humanism, growth potential through self-insight. The method used in client-centered therapy would be active listening and unconditional positive regard. Behavior therapies like John Watson or the theories of B.F. Skinner would be that the assumed problem for depression or anxiety would be maladaptive behaviors that you have, that you've somehow developed in your life. The therapy would be to use behavioral techniques to extinct those behaviors and relearning more adaptive ones. The types of methods that are used in behavioral therapies would be counter-conditioning, exposure therapy, systematic desensitization, some type of aversive conditioning if it's an addiction that you can't quit, or even types of shaping, behavior shaping or behavior modification in the form of operant conditioning. Cognitive therapy is going to assume that your problems are the result of negative self-defeating thoughts. So again, cognition is thoughts. The aim of the therapy would be to retrain your thinking to be a thought process that's a little healthier. And the method that's used in cognitive therapy would be to reveal and reverse the self-blame that depressed people suffer from. Family therapy or group therapies would assume that your psychological problems stem from relationship issues or stressful relationships. The therapy or the goal of therapy would be healing those relationship dynamics, and the method that they use would be training, teaching dynamics of the family social system, exploring and explaining family roles or roles within the family dynamic, and improving the communication inside of the family. So when we get to the evaluation side of things, you have to look at the good and the bad. How long is this successful for? When you do these types of therapies, are they foolproof? Are there issues? Are there confounding variables? How accurate are there? There are other things that we have to consider that may possibly also be what's helping the client rather than just the therapy itself. So you certainly have your skeptics, right? They often are people, the skeptics would point out that people who enter psychological therapy are in a state of crisis, and so they really have nowhere to go but up. They obviously have to buy into the idea that therapy would work in order for it to actually be successful for them. So that is one criticism of therapy. And also clients who are seeking help tend to speak kindly of their therapist because they also tend to believe that the therapists are competent people who know what they are doing. They don't tend to think that the therapist is not able to help them. From the clinician perspective, the medical professional is going to seek to help clients overcome their anxieties and depressions and things like that. And essentially the assumption is that if a client stops coming to therapy, then they must be doing better, feeling better. And how do we analyze whether or not this is successful? Following up with the clients. And then, of course, how do we know using analysis if therapies are successful? We look at the data. We look at the analysis from longitudinal studies and case studies. So again, you can look at that. Therapists in training, this is just kind of the difference between the titles and what they do, what they're responsible for. You have counselors, which is a term for people who do group therapies like marriage and family. They specialize in problems arising from family relations. Pastoral counselors provide counseling to countless people, so those would be people, some type of clergy or a minister and some type of a religious counselor. Abuse counselors work with substance abusers and with spouse and child abusers and their victims. Of course, you have grief counselors, who come to schools and things like that after a tragedy. So those are the types of group counselors. You also have therapists that are clinical or psychiatric social workers. And how they become a clinical or psychiatric social worker is not an MD, it's a 2-year master of social work, a master's degree in social work, plus some type of postgraduate internship. right? They can offer psychotherapy, mostly to people with anxiety and depression and things like that. They can offer family therapy, but they cannot prescribe medication. So about half of clinical or psychiatric social workers have board certification through the National Association of Social Worker and Clinical Social Workers organization. You have clinical psychologists, which is another type of therapist that you can see or that you can become. Most clinical psychologists are PhDs or PsyDs, which is a doctorate of philosophy in psychology, not just a general PhD. They have expertise in research fields because that's what they spend most of their graduate work and their PhD work doing, or PsyD work doing. They are able to gather data from assessments. They can perform therapy. They can they can supplement their school training with supervised internships, postdoctoral training. They usually are placed with nonprofit organizations or schools, and about half of which actually have their own private practices. And then the top level, which could perform all of the psychological and psychiatric duties, would be an actual MD, a medical doctorate in psychiatry. So psychiatrists are actual physicians who specialize in the treatment of psychological disorders. So the same level of medical training as a physiological medical doctor, but they are able to prescribe medication, and they specialize in neurological and psychological disorders. So not all psychiatrists have had extensive training in therapy, but as medical doctors, they can prescribe medication. So they tend to see those with the most serious problems. Many of them own their own private practice, which is where most of the money is in private practice medicine. So again, that's worth noting that psychiatrists are therapists, but they may not be trained in the therapeutic techniques like some clinical psychologists are, because they are medical doctors and not necessarily specialists in psychological therapies. Then we get into biomedical therapies. That's going to be anything that changes the physiology of the brain or body. So things like drug therapies. The term psychopharmacology, when you break it down, really means the study of how drugs affect the mind. Antipsychotics, that is one type of biomedical or drug therapy. So you have things like Seroquel, which is an antipsychotic, meaning that it is a dopamine antagonist, right? So anything that is going to help hallucinations or delusions that are symptoms of schizophrenia. Those are going to be things that decrease the amount of dopamine in the brain. The downside to decreasing the amount of dopamine in the brain is that it can create tardive dyskinesia. Dyskinesia is involuntary twitch movements of the muscles in the body. It can even be facial muscles. It can be the tongue. It can be the eyes. But you see that in similar symptoms in Parkinson's patients, or people who have some level of dyskinesia. Tardive dyskinesia specifically means involuntary movements that have come from drug use, whether it's illicit drugs or prescribed drugs. Dyskinesia means involuntary bodily movements. Tardive dyskinesia refers to drug-induced dyskinesia. So you have things like dopamine antagonists. The original dopamine blocker that was used for schizophrenia and mood stabilizing was lithium, and now you have things like chlorpromazine, you have Seroquel, and you have other antipsychotic drugs that are widely prescribed. They have a lot of side effects. Because they're decreasing the dopamine in the brain, they are decreasing the motivation that comes from dopamine in the brain. So a lot of times people see decreased appetite, a decrease in their sex drive. So many schizophrenic patients don't like taking antipsychotics because of the side effects. There's other agonists and antagonists to be aware of. You have SSRIs, which are selective serotonin reuptake inhibitors. SSRIs block the reuptake of serotonin in the serotonin pathways, therefore allowing the brain's natural levels of serotonin to stay in synapses longer, therefore helping to stabilize mood disorders like depression or bipolar. And you have drugs like Xanax or Ativan, which are SNRIs, selective norepinephrine reuptake inhibitors. What they do is they help to calm the sympathetic responses of the body by blocking the reuptake of norepinephrine, which is kind of the counteractor to sympathetic nervous arousal, things like epinephrine. Again, antidepressants, SSRIs, it even helps with things like OCD. Increased availability of norepinephrine or serotonin help with mood disorders as well. So sometimes if people have bipolar disorder, like bipolar 1, taking an SSRI can help regulate the levels of serotonin in their brain, not just someone who has depression. In teenagers and young patients, a lot of times psychiatrists will prescribe SSRIs as an anti-anxiety medication rather than something like Xanax, which is an SNRI, just because it is something that's a little bit safer and more manageable for a developing brain to increase the serotonin levels in the brain instead of increase the norepinephrine levels in the brain. You have mood stabilizers, again, things like lithium. Biomedical therapies, so these are things that affect the physiology of the body or brain, but are not drugs necessarily, agonists or antagonists. So you have different types of therapies like ECT, which is electroconvulsive therapy. The idea behind that is that if your brain is electrochemical, then sending shocks of current through the brain synapses could essentially help to rewire the circuits of the synapses that are connected. It was really a barbaric process at the beginning because it was essentially electrocution without anesthesia for fully conscious patients. Now, ECT is still used in extreme cases, especially in extreme depression, extreme bipolar, or in cases where people have massive levels of hallucinations. And the idea behind ECT is to help rewire the circuits in the brain, so to speak. But now it is anesthetic and is people who are, again, anesthetized and they are not feeling and experience the electrical current. You also have alternative neurostimulation. So if you don't use electrical currents, you can use magnets. You have RTMS, which is repetitive transcranial magnetic stimulation. You can see a diagram of what that looks like to the right there with the magnetic wire coil that's placed on the cranium. And the idea, again, is that if you can change the polarization of the neurons, then you can get them to fire, or you can get them to depolarize, and possibly even to get dendrites to grow and reconnect in new synapses. So it's using magnets and a magnetic field across the cranium as opposed to an electrical shock throughout the body. Other forms of biomedical therapies, you have some older therapies of things that are a little bit more archaic and are not really used now. So things like frontal lobotomies or other types of brain surgery that lesions or cuts out or destroys the tissue of the brain. So if you're getting to psychosurgery, it is an extreme level of psychological trauma or disorder that really has been resistant to other therapies. Psychosurgery is a kind of a last result. It's very dangerous to perform any surgery on the brain, especially when you're removing the skull cap or if you're puncturing the dura. Even now, neurosurgery is used as a last resort, and it's usually for things like tumors in the limbic system and things like that. If they're operable and they can be reached, and they can't be treated with traditional cancer therapies like radiation or something like that. So psychosurgeries are not common. They're expensive. They're dangerous. They are potentially hazardous to changing the chemistry and the makeup of the brain. If you damage tissue in the frontal lobe, you could change personality traits, you can eliminate memories, it can have all kinds of issues. And then you have therapeutic lifestyle change, which is something that's similar to other humanistic approach, where the idea that if you take control of all the aspects of your life, you can fix negative parts of your mind or issues like depression by changing your chemistry. So that is chapter 13, and stay tuned for chapter 14.